Thanks for downloading and welcome to Take Aurally, the podcast from Rhinne Medical Centre at Nottingham. In this episode, we'll be discussing examining the ear, nose and throat. As ever, all information is correct at the time of recording. Any and all guidelines mentioned are correct for Nottingham University Hospitals, NHS Trust. Other trust guidelines may vary. All views and opinions are the speaker's own. Hello, welcome back to Take Aurally. This episode is on examining the ear, nose and throat, and we have Lucy Harris back with us. Hello, Lucy.
Hi.
And we're going to go through in a systematic approach examining the ear, nose and throat in this episode.
Absolutely.
Awesome. Very common to see patients in A&E and in primary care coming in with some sort of ENT problem.
Absolutely. Sometimes just incidentally and nothing to do with why they've actually attended.
Absolutely, as we were just talking about. So what we're going to go through then today?
So looking really at the examination of the ear, nose and throat, divided really into sort of ear, nose and throat, aptly. But looking at the cardinal symptoms of the ENT system and identifying any equipment that might be required for that, and then how we go about conducting our examination. And also discussing some of the common pathologies associated with the outer ear, tympanic membrane, nose and throat as well. Marvellous.
Okay. So where are we beginning then?
As with any prior to any examination on a patient, we would be taking a full history and thinking about using Socrates in terms of analysing their symptoms and presenting complaint. And being very clear on what were symptoms and what are signs, so what the patient's actually complaining of, and then the signs of the disease process that we could potentially be picking up on during our examination, and thinking about the cardinal symptoms of both the ear, nose and throat.
Remembering that pain is the symptom, tenderness is the sign.
Absolutely. Pain is a symptom.
So, speaking about
is a sign.
So, speaking about symptoms, what sort of symptoms are our patients going to be complaining about if we're thinking about the ear in particular?
So, lots of very long words need to swallow a medical dictionary, really. In terms of thinking, you mentioned pain before, Jamie. So, earache or atalgia, itching, so pruritus, discharge, otorrhea. Hearing loss, obviously one of the biggest complaints that people will come in with. Ringing of the ears, so tinnitus, of which there are lots of underlying reasons for that. Vertigo, so hallucination of movement essentially, or feeling unsteady on their feet.
Vertigo is not a fear of heights, despite what people say. It is the hallucination of movement.
Hallucination of movement, absolutely.
Cool.
So really, I guess before even starting, it's a good idea to familiarise yourself with the basic anatomy of the ear. I was in a lecture recently where a lecturer asked the students to draw their own ear, which I thought was quite interesting because I don't know if I've examined my own ear at any great detail. Being on the side of my head. But yes, it's very, really important just to know the anatomy of your outer ear, middle and inner ear, and how they're divided up actually. So you've obviously got your helix, your pinna, I should say, on the outer ear, which is made up of your helix, concha, and earlobe at the most basic. With your tragus at the front there. Obviously, what do we use the tragus for as well?
Checking for tragal tenderness.
Tragal tenderness. Oh, but it gets mentioned in ALS, doesn't it, in terms of measuring out your Goodell airways?
Oh, yes, it does indeed. Yep.
And then moving on to the middle ear, which essentially is your external auditory meatus, and where you'll find lots of mostly benign pathology in patients. So if you're thinking about upper respiratory tract infections or external ear infections, then essentially that would be the part you're looking at. And then at the end of that, you've got your tympanic membrane as well. And behind that, you've got, a lot of things going on, lots of tiny bits of anatomy going on. So thinking about the auditory ossicles, your hammer, the malleus, your anvil, the incus, and your stirrup, which is your stapes attached to your oval window. all of which then essentially go on to join onto the cochlea and the semicircular canals filled with fluid. It probably was some of the most interesting anatomy that I learned during my training as an ACP, actually. I think I found this really exciting. Maybe that is just me. But actually, it's fascinating how this all works. Actually, it's so intricate, isn't it?
It is very cool. Excellent. So our order of examination is the same as before, as with all systems, any body part that we're looking at.
Yeah, so thinking about preparing the patient, obviously gaining consent, your inspection, palpation, and then, I don't know, do you say oroscopy or do you say otoscopy?
Well, I mean, this is Take Aurally as a podcast, but I usually say otoscopy.
Otoscopy? Oh.
Otoscopy, otoscope, I don't know. James Pratt takes the mick out of how I say words like that anyway.
And then at the end, you're going to be thinking about your special tests that you're going to perform as well.
Yeah.
So general inspection of the external ear, need to be comparing both sides, looking at the pinna, the pre and post-auricular regions, the external auditory meatus, which I mentioned before, and the types of things that we would be looking for would be sort of any signs of scars, particularly patients who might have had sort of things like mastoidectomies, where it may be slightly more apparent. Things like hearing aids, I mean, keep it simple. The things that are very obvious, so hearing aids, looking for swellings, any lesions, any exudate from the ear, or any bruising around the ear externally as well. Something we probably see more commonly in an ED setting, really, in terms of injury. I guess one of the things that I was taught, and one of the hammer home messages from my teaching was any kind of swellings behind the ear, a bit of a red flag really, and for an ENT speciality review, because you're thinking about things like mastoiditis and abscesses behind the ear, leading on to further complications. So I guess there's a requirement there to know which specialty you're going to be speaking to and referring on to in a timely fashion as well.
Cool. And then palpation?
So palpating, you already mentioned the tragus, so palpating around the tragus. Commonly with external ear infections, that people will complain of sort of tragal pain, typically saying it hurts when I push here, which generally the answer is don't push there. So pain around the tragus, the pinna, around the TMJ, so you think about things like TMJ dysfunction with referred pain as well. The pre and post-auricular regions, which we spoke about before, so palpating for sort of any tenderness really, or any collections that you might be able to feel under the skin as well. And then moving on to have a look in the ear. So this is something that I wasn't actually taught within my mainstream ACP training, and it's something that I did in addition in terms of looking in people's ears, which is something that actually you use so frequently. It's a really important skill, so consequently has been added to some of the examination skill sessions in the afternoons this year as well. So pulling the pinna up and backwards, I guess having an understanding firstly of what your otoscope can do and how you use it would be the most crucial thing. So familiarising yourself with your equipment. Make sure that you're using the biggest biggest speculum that the patient could tolerate. Obviously we all have different size ears, but generally if you can go for the bigger one, that's better, because you'll see more of the tympanic membrane in one shot. So within adults, you pull the pinna upwards and backwards. Within children, obviously they have a straight canal already, so don't do that. Use the finger just to rest against the patient's cheek as you're positioning the oroscope or otoscope, whatever you prefer to use. Just because if the patient's moving away from you, you're likely to sort of go with them rather than pull away, and you damage their ear or hurt their ear further. Sure. We're looking for canal skin changes, specifically things like foreign bodies, which we see frequently in ED, inflammation, any vesicles, if you're thinking about something like Ramsay-Hunt as a presentation, or any sort of herpes zoster type presentation, and discharge or wax within the ear.
Yeah, just remember that you're holding the otoscope or the oroscope, whatever you call it, you're holding it in the hand that's on the side of the ear that you're examining. So you hold it in your right hand if you're examining the patient's right ear, and you hold it in your left hand if you're examining their left ear.
Yeah, ambidextrous. We all need to be.
You need to get a bit ambidextrous, yeah, absolutely.
So once you've had a look at because I think there's a temptation, isn't there, when you look in somebody's ear to head straight for the tympanic membrane, and actually you do need to look at the canal as part of that process. So take your time, try not to rush this. But moving on and looking at the tympanic membrane, I think this is probably quite familiar for most people. And looking at normal membranes, I would say you just need to look at a lot of ears really to know what's normal and what's not. But essentially, you will see your handle of the malleus coming down the middle, which is the most recessed point of your membrane at the umbo, and then you've got your cone of light on generally the right hand side lower quadrant. You've at the top, just for completeness, you've got your pars flaccida, and then on the left side your pars tensa. And you might be able to see the lateral process of the malleus potentially. There's some really good videos actually on YouTube. McLeod's has a very good one, which I've put the link within our lecture here today. But if you were searching, then you'd be able to find it fairly easily on YouTube.
What should you look for on YouTube? Who's it by?
McLeod ENT examination.
Cool. And so if you think then about what sort of positive findings we might find then as we're examining our patient's ear, what are we thinking about?
Oh, I mean, there's a wealth, isn't there, really? So we're really only going to be touching on a few. But specifically from an ED perspective, I guess we see a lot of things like hematomas behind the ear, or the pinna itself. So from injuries, essentially, Saturday mornings, rife with rugby injuries. So hematomas as a result of trauma. Thinking about how that would later impact on. Thinking about how that would later impact in terms of the aesthetics of the ear, unless that's treated appropriately. So whether you need to drain that hematoma. And damage to the cartilage beneath, if that wasn't to be done. And then looking for things like preauricular sinuses. So lots of people have them. Actually, until I learnt this, I wouldn't have really noticed the tiny little dot in front of people's ears. Realistically, I mean, it wouldn't really impact on their life hugely. It just potentially would act as a route for infection. So they might be at greater risk in terms of infection there, but it's just a tiny hole in the front at the top of the ear. Accessory auricles, which are just small tags, cartilage tags, or microtia, which is the failed development of the ear, so somebody who doesn't have a complete pinna formation. And looking for things like skin cancers are incredibly common. I think it's one of the things that we're very bad at, which is putting sunscreen on our ears. We managed to do it everywhere else. But thinking about if you do see a lesion, then actually that's something that does need to be sort of sorted and referred on.
Absolutely. And when we're actually looking inside the ear, what sorts of stuff can we find in the ear canal? So
thinking about the ear canal and findings within the ear canal, I guess wax.
Yep.
It's probably
a lot of wax, yeah,
the most
absolutely.
common finding, mostly blocking the viewpoint, so you potentially won't see the tympanic membrane, which is frustrating. So wax, and then thinking about sort of the inflammation of the external canal, as in sort of otitis externa. Foreign bodies, again, probably not as common with adults, maybe the paediatric side of things, she says with an 18-month-old. And cholesteatomas is one of the other things that we need to be aware of, and actually it's quite an important pathology. If you do find it, even as an incidental finding, that it needs really a referral to ENT for them to monitor that, as it can lead to sort of hearing loss essentially. So actually, if we're picking up the early signs just on the off chance of licking somebody's ear, then actually that's something that would need referral anyway.
Absolutely.
So, thinking about findings further in the ear canal, so looking at the tympanic membrane, so you see things potentially like perforation of the membrane. I think once seen, you will never forget a perforation.
No.
It's very clear. Retraction of the pars tensor is something else you might notice as well. And actually, it's one of those that actually, unless you're looking at lots of ears and become quite competent at looking at ears, that actually you might mistake that for a perforation when it isn't. Otitis media is the other thing that you would be looking for specifically when you're thinking about ear infections, whether we give antibiotics for ear infections. Now this is a moot point for the community because I know that there's huge restrictions with regards to antibiotics and what we should be treating with antibiotics. So otitis media is something that we would consider antibiotics for, whereas otitis externa isn't really something that requires an antibiotic therapy. And signs of otitis media could be like a bulging of the tympanic membrane. You may see an effusion behind the membrane itself, so you can see like a fluid level. Sometimes what you can see is a fluid level with bubbles behind it, and that's sort of a resolving infection where the eustachian tube is actually clearing, so air is now going back up to the ear and causing that sort of bubble effect.
Cool. And I think it's a good habit to get into if you see a perforation is to try and describe it from, imagine the face of a clock. So I think if you're documenting, because they obviously can change, they can extend, so you can say, there is a perforation from 6 o'clock to 9 o'clock, for example. And then if the next day they're seeing it's now from 6 to 12 o'clock, you know that it's getting a bit bigger.
That it's extended out.
I think that's because otherwise you find yourself doing these weird and wonderful bottom quadrant or whatever, and keep it simple, I think. Right then, so now on to the bit that we definitely didn't have to look up at all or do any sort of
just to check
at all. So now we're on to our special tests to do with hearing. We're on to the 8th cranial nerve here, vestibulocochlear nerve. How are we going to assess our patient's hearing?
So, the elusive Weber's and Rhinne's testing.
Yes.
Which, I mean, in all honesty, I don't know if I've seen it used in practice myself. I learnt it, obviously.
For exams, yeah. And
I would say that maybe advances in technology have superseded this slightly, but I think it's a good basis to know about it. Should you be in a position where you don't have the technology available.
Absolutely.
And let's be honest, we are heavily reliant on that now, and so we're losing some of these really amazing skills that we had before. So, so Weber's essentially is a screening test to establish if there is hearing loss either side.
Cool.
Whether that be perceptive or neurosense or conductive. So essentially, screening. So you're screening to see if there is a hearing loss and which side that hearing loss is. If it's heard louder in one ear, then a Rhinne's test should be carried out.
So this is your 512 hertz tuning fork. You give it a tap, you place it in the forehead of the middle of the forehead of the patient, and it should be heard equally in both ears.
Heard equally
so
both
you say,
sides.
can you hear it equally in both ears? Is it louder than one or the other?
Yeah, and if it's heard louder on one side, it could indicate perceptive deafness, in which case it would lateralise to the intact ear. And if it's conductive deafness, it'll be lateralising to the damaged ear, as in bone conduction would be louder. I will say one of the videos that I watched with somebody performing a Rhinne's, a Weber's and Rhinne's test, suggested that when you hit your tuning fork, it's on your own leg and not the patient's.
Wow.
Yeah, I know.
So people have been doing that, have they, whacking the patient?
How very specific.
You may as well assess their patella reflex while you're examining them. Cool, so if you've got a conductive hearing loss, Weber's will go towards that ear. If if you've got a sensorineural hearing loss, it goes away from that ear. But we're going to do Rhinne's after Weber's. So if Weber's is abnormal, we do Rhinne's.
We move on to do Rhinne's, exactly. And essentially that's hitting your tuning fork on your own knee, not the patient's knee, and holding it on the base of the mastoid process, and asking the patient to tell you when the sound stops. And essentially then you move the tuning fork to the side of the ear, next to the external auditory meatus, and ask them if they can hear it. And essentially they should be able to hear it because air conduction is louder than bone conduction, so they should continue to hear the sound.
This is where the description you use. So a positive Rhinne's test is actually normal, because we always think positive is what happens in an abnormal environment. So positive Rhinne's test is your normal, which is where your air conduction is going to be bigger than your bone conduction. Okay, both of those will be reduced if you've got sensorineural hearing loss, but in conductive hearing loss you get bone conduction will be louder, better than air conduction. Absolutely. And that was what we call a negative Rhinne's test. So if you do a Weber's on your patient and they hear it better in their left ear, and then you do Rhinne's on that left side and bone conduction is better than air conduction, you can say that that patient's got a conductive hearing loss in the left ear.
And refer them to ENT.
And refer them to ENT and get some specific tests with their 21st century technology rather than our Victorian technology that we sometimes have to still use in A&E. Whereas if it's a Weber's test that lateralizes to the left ear, but on the left ear air conduction is better than bone conduction, that suggests it's a sensorineural hearing loss on the right side.
Yeah, absolutely. I guess one way to sort of, I think when you read a lot of the text about the Rhinne's test now, is essentially they try to get you to not use a positive and negative in terms of your terminology, because actually it's just confusing. So just explain what your patient is saying they're hearing would be a much simpler way to do it.
Marvellous.
Moving on to nose.
That's Weber's and Rhinne's, which we no way had to look up. So now we're having a look at our patient's nose. And again, we work in A&E. It's mostly trauma here again. I've been punched, I've been in a rugby tackle. Now my nose is bendy.
So the other thing that you'd need to consider are things like postnasal drips, coughs, I think as a result of that as well. Sinusitis. People complain of frontal headaches and things like that. That is going to a whole different realm of podcast, I suspect. So symptoms of the nose could be, you've already mentioned bleeding as one of the things, so epistaxis, but discharge, so rhinorrhea, any type of rhinorrhea, sneezing, coughing, a blocked nose. I feel that pain. Pain itself, deformity, and change in smell. So an absence of smell, anosmia, reduced smell, hyposmia, and then an unpleasant smell. Cacosmia.
There we go.
Cacosmia. Examination is exactly the same. So it's essentially a prepare, inspect, palpate, and then your special tests. Not forgetting, obviously, to get your consent of the patient before you play with their nose. So looking at the external nose, looking at the surface, and notice any deformity. And that would include things like any sort of deviations of the septum that you can see externally, and which might be an indication of previous nasal fracture. And then actually inspecting the nasal flares themselves. You can use an otoscope or oroscope, looking at somebody's nose as well if they would tolerate it. Particularly in injury, sometimes that's quite difficult, but certainly there is going to be a need for some form of light, so whether that be a pen torch to help you, but actually an otoscope would give you...
Because you're going to want to look for a septal haematoma in trauma.
So within trauma,
which is one of the findings, which moves us on to findings.
So within the context of trauma, that you would be looking for any signs of septal haematoma. Essentially, it's a red cherry in the middle of somebody's nose.
Pretty much just imagine a cherry, and that is what a septal haematoma is.
The other thing that you would be looking for as well, in the absence of things like trauma, would be sort of septal fissures, so holes within the septum itself, of which there is lots of different reasons. Piercings is one.
Yep.
The use of drugs, so I think it was well publicised quite a few years ago, the use of cocaine and how that destroys the septum.
The actress who played one of the Mitchells,
Daniela
Westbrook. That's it. She lost her septum and had to have one made. There we go.
Absolutely. So looking for signs.
Cutting edge. Cutting edge. Popular culture there. That well-known
Heat magazine.
Heat magazine. That well-known medical journal. Yeah. Anyway. Yeah. That case report.
And then hypertrophy of the turbinates, so that's it within the nose, which may cause mouth breathing for patients, but also disturbs sleep as a result of this. It's a big issue, isn't it, that things are going on, because actually you can end up with disturbed sleep pattern overnight, impacts on your day, not good. And then the other thing to think about is nasal polyps. Growths, essentially they're painless at the lining of the nasal passages, and patients might complain of increased snoring at night time, altered sleep pattern, feeling tired when they're waking up. Obviously there would need to be further potential investigations to see why that is happening. So thinking about things like obstructive sleep apneas and things. But certainly that's something that would need referral on to ENT, and then essentially potentially a removal of the growth.
Cool.
So palpating, so feeling the nasal veins gently, particularly in the presence of trauma. I found that they don't tend to like you touching their nose if they've broken it.
No.
So very gently palpating along sort of the bridge coming down the nasal cartilage. So you can distinguish the sort of bony deformity from any cartilaginous deformity. I'll check the integrity of the infraorbital ridges as well, and range of movements of the eyes, particularly in things like trauma, just to exclude things like orbital blowout.
Yep.
And then palpating also for cervical lymphadenopathy. Also.
I sometimes, especially in trauma, I ask the patient, not me, to occlude one nostril and try breathing through the other one to check for nasal patency as well.
I'd have no hope today, Jamie, at all.
Mouth breathing only.
Mouth breathing only for me today.
Oh, bless. Marvellous. And so that is the nose. And we are now on to the throat with E, N and now T. And so, again, a very common scene in A&E and also in primary care, patients coming in with
quite a few people coming in with flu.
Throat symptoms, absolutely.
Symptoms at the moment.
So what sort of throat symptoms is our patient going to start
so I think probably the biggest thing that people will complain of is pain, isn't it?
Sore throat.
So sore throat or pain on swallowing, so adolophagia, so pain on swallowing. They might complain of a hoarse voice. They might complain of trismus, they're not able to open their mouth fully. A dry mouth, having bad breath, so halitosis, upper airway wheezing, sort of stridor, something that we would be pretty concerned of if we saw that. So it's a big red flag there before you even laid a hand on the patient. And then complaining of any sort of lumps in the neck, which could be a sign of lymphadenopathy.
At this point, I would signpost you to the podcast on the sore throat podcast that we did a few months back. Cool. So we've now going on to our examination of our throat then. So what we're going to be looking and listening.
So very much the same as before. There's a structured approach, isn't there, of preparing the patient, consenting them, listening. So the first thing, because we've already mentioned here, sort of upper airway noises, so things like stridor. So that is a thing to have as part of your examination process at the beginning, and then inspecting and then palpating. So listening wise, I've mentioned stridor, but vocal changes that could change with pathology of the throat. So having a rough voice. Mine sounds a little bit rough today, so with a sign of sort of vocal cord pathology, whether that would just be some inflammation from an upper respiratory tract infection or something more serious underlying it. They could sound breathy, and maybe an indication of recurrent laryngeal nerve palsy. A wet, hoarse or dysarthric voice, thinking about neurological reasons behind that, whether acute or chronic. A muffled voice within the context of oropharyngeal masses, like the lady we discussed previously. A nasal escape, so soft palate dysfunction, for instance, cleft palate. So inspection of the mouth is key. It's something that I mean, as part of your cardiorespiratory exam, you do have a look in the mouth.
You do.
And part of the GI exam, you look in the mouth. So actually, knowing your anatomy of the mouth is pretty essential. And what I would say is that obviously there is a concise examination that we do as part of those, but this is actually much more thorough. So in terms of inspection, a thorough examination would include looking at dentition, starting with the hard palate, looking at the hard palate and moving to the soft palate, checking the uvula, so seeing if there's any inflammation of the uvula at the back there, thinking about uvulitis and things like that. Consequently, I've only ever seen that a few times, that when people do come with it, they're incredibly uncomfortable and they can't stop gagging because it's just tickling at the back of the throat and initiating their gag reflex. Then thinking about the posterior pharyngeal wall, so in terms of colour, if there's any exudate there, if there's swelling there, and then the tonsil region, so the tonsil either side, if they're inflamed, if there's any exudate on those, or if there's evidence of scarring where they've had a recurrent tonsillitis in the past, you'd be able to sort of see that. And then moving down, looking at the tongue itself, so looking for any sort of ulcerations, looking for any sort of cracks within the tongue, which could be signs of dislocated tongue really, which can be benign, but also thinking about any underlying pathology that could be causing it. I would also say to look under the base of the tongue as well, so looking at your frenulums, just to check to see if there's any changes there. I guess within children that would be a sign of sort of non-accidental injury, essentially, in the absence of a trauma, so something to look at there. I tend to find when I'm inspecting somebody's mouth, actually sometimes you need to have a tongue depressor and you need to have a pen torch really to have a thorough look, and actually there is a point when you're examining somebody's mouth that actually you actually put your fingers in and have a feel around sort of the base and around the edges as well, in terms of being thorough, and not to miss anything there.
Yeah, absolutely.
So looking for discoloration, swelling, inflammation, ulcerations or nodules. The patient's bite. I can't really say that without biting. And tongue deviation. Any other findings that you might see are things like thrush.
Nasty white sore.
Yeah, you can get leukoplakia on the tongue as well. Incredibly common, particularly those who smoke. And it's something that resolves itself normally once people stop smoking. And then the next thing would be things like dental caries.
And ulcers, very common.
Yeah, and kind of not isolating it just to the mouth, so thinking about sort of systemic disease that could cause that, things like Crohn's, in terms of a first presentation, and putting it all together.
So again, the podcast on sore throat has a very good section about examination, things that you can find, especially about tonsils and peritonsillar abscesses. So I really recommend giving that podcast a listen to.
Yeah, and ongoing management.
Yeah, absolutely. Is that it?
Yeah, I think that's it.
Marvellous. You can go and blow your nose now. And that is ear, nose and throat examination. Thank you very much, Lucy.
Thank you.
That was the Examining the Ear, Nose and Throat podcast. Remember, you can find the blog entry for this podcast at www.takeaurally.com, where you can subscribe to Take Aurally on both SoundCloud and Apple Podcasts. For more, you can also find Take Aurally on both Facebook and Twitter. For more information about research and educational opportunities within emergency medicine and acute medicine major trauma, don't forget to check out NUH Dream on both Facebook and Twitter.